Congenital lobar emphysema. Congenital lobar emphysema is also known as congenital alveolar overdistension or congenital large hyperlucent lobe. It is a developmental anomaly of the lower respiratory tract characterized by hyperinflation of one or more pulmonary lobes. It is a rare condition which occurs 1 in 20 to 30,000. Males are noted to be more affected with a ratio of 3:1. One-third of them are asymptomatic at birth, but nearly all are diagnosed within the first 6 months. Rare cases were reported in late childhood or early adulthood. The different pulmonary lobes are variably affected by congenital lobar emphysema. The left upper lobe is affected most often at 42%, followed by the right middle lobe 35%, right upper lobe 21%, and lower lobes at 2%. Congenital lobar emphysema rarely affects multiple lobes. Looking at the development from the lower airways, starting from the trachea downwards. The trachea divides into the right and left main primary bronchi. These are going to enter the right and left lungs. They then divide into secondary bronchi and tertiary bronchi. The tertiary bronchi divide into bronchioles, which lead into terminal bronchioles, and then into respiratory bronchioles. Each of the respiratory bronchioles leads into few alveolar ducts, which then lead into alveolar sacs. So this portion is the respiratory zone where gas exchange takes place, while the rest is the conducting zone, which just conducts air towards the lower airways. The three germ layers are the ectoderm, the mesoderm, and the endoderm. Now let's remove the ectoderm. These two, they form different portions. The airway have different structures on their wall. These walls would differ depending upon what level of airway we're looking at. Overall, some of the things that would be located there would be the epithelial lining. And there can also be smooth muscle, cartilage, and connective tissue. The epithelial lining is from the endoderm, while all the others are from the mesoderm. So these are the embryological derivatives. But how do they form? We start at week 4. So this is the primitive gut tube or foregut. The upper portion of the cranial portion is where you can find an outgrowth. This is the diverticulum, the respiratory diverticulum. The lower or the caudal portion of this diverticulum is going to form the lung bud. The diverticulum is surrounded by the splanchnic mesenchyme to form all the mesodermal derivatives discussed earlier. So the upper portion of this diverticulum would contribute to the trachea and the larynx, but the lung bud is going to form the respiratory tree. So the bronchial buds will form the bronchi, and the bronchular buds will form bronchioles. So from the lung bud, there's the left and right primary bronchial buds. Before we go any further, you can see now that the trachea is and the gut tube, which is going to form the esophagus, is now connected. But this has to close. How? For that, we have to flip it over and look at it from above. This is the developing trachea in front and the esophagus behind. These are folds that are going to form longitudinally the tracheoesophageal folds. They fuse in the midline to form the tracheoesophageal septum. So now both of them are separate with a ventral trachea and a dorsal esophagus. Now what would happen if something went wrong here? So a fistula or a communication remains. This is the tracheoesophageal fistula. Once the septum forms, the trachea is now separate. These bronchial buds with their mesenchyme push into canals called the pericardio-peritoneal canal, and these canals are going to form the pleural cavities. As the name implies, they connect the pericardial and the peritoneal cavities. So as the bud grows through these canals, the communication between these two cavities has to close, and that happens by folds which then form membranes. So to separate from the pericardial cavity, there's a pleuropericardial membrane, and from the peritoneal cavities, there's a pleuroperitoneal membrane. So that's how they separate. We have to remember that the pleural cavity is lined, so the portion that's attached to the lung, the visceral pleura, will also develop from the splanchnic mesoderm, and the parietal pleura, which is toward the body wall, is from the somatic mesoderm. Going back to the respiratory tree, from the tertiary bronchi, we have the bronchioles, the terminal bronchioles, the respiratory bronchioles, alveolar ducts, and alveolar sacs. Now we're going to split them into two each. The first two, the second two, and the alveolar sacs. So the stages overlap, so it can't actually be divided like this, but this is something done to make it easier to remember. So the tertiary bronchi form bronchial buds, which give rise to the bronchioles, and they lead into terminal bronchioles. We also have to remember that these are histological stages, so these are the terminal bronchioles with their lining, and around that is the mesenchyme, which gives rise to the connective tissue, and also importantly is where capillaries form. So at this point, the lung sort of looks like a gland, so it's called the pseudoglandular stage, which is from 5 to 17 weeks, or easier to remember is 6 to 16. So in Candidates, it is 6 to 17 weeks. Now the next two steps, that's the respiratory bronchioles leading to the alveolar ducts. This is the canalicular stage. So from the terminal bronchioles, we have the respiratory bronchioles, and each respiratory bronchiole leads into a few alveolar ducts. So new smaller canals are forming, and the canals which were formed in the previous steps, like the bronchi and the bronchioles, are going to get wider. So it's all about the canals. That's why it's called the canalicular stage. The capillaries formed in the previous stage are going to increase. So this is around 16 to 26 weeks. The alveolar ducts lead into sacs called the alveolar sacs. So this is the terminal sac stage or the saccular stage from 26 weeks to birth. These alveoli are primitive. Now the lining flattens and the cells are flatter. These are the type 1 cells which are very important and are needed for gas exchange. So the capillaries come really close to the alveolus. This is the reason why these type 1 cells are thin. It is to make it easier for gas exchange. And there you can also see type 2 cells, which forms the surfactant. In the alveoli, there's an air-fluid interface that can create surface tension, which can cause small alveoli to collapse. Surfactant is a phospholipid which lines up inside the alveolus, and it reduces the surface tension. It gets synthesized during the stage, but sufficient amount is needed, so the levels increase with gestation. So what we have here in the saccular stage are primitive alveoli, which has to mature and proliferate. So there are millions of alveoli at birth, but they proliferate into millions and millions more. And so that's the alveolar stage, which is from birth to 8 years, where they mature and proliferate. So that's the 4 stages of lung maturation: the pseudoglandular stage, when it looks like a gland; the canalicular stage, when it looks more like a lung; the saccular stage, when the alveolar sacs form; and the alveolar stage, when the alveoli proliferate. So there is no uniform etiology on CLE. Up to 50% of cases have no cause, while congenital defect of the cartilage presents in 25%, and other causes of bronchial obstruction underlying the remaining 25% of cases. Additional evidence has been shown for a possible inherited factor as etiology. Roberts et al. Reported 2 cases in a father and a son secondary to deficiency of bronchial cartilage. The etiology of congenital lobar emphysema can be due to an intrinsic or extrinsic obstruction. So, intrinsic obstruction is when something from inside the lung is causing an obstruction of the airway, and this is the more common cause of obstruction. It is often caused by defects in the bronchial wall, such as deficiency of bronchial cartilage. This results in airway collapse during expiration. Intraluminal obstruction caused by meconium or mucus plugs, granulomas, or mucosal folds can also cause partial obstruction of the lower airway. Extrinsic compression may be caused by vascular anomalies such as pulmonary artery sling or anomalous pulmonary venous return, or intrathoracic masses such as foregut cysts and teratomas. Additionally, bronchial atresia has been identified as a common finding in CLE and other congenital cystic pulmonary malformations. Some cases are caused by easily identifiable partial obstruction such as mucosal flaps or twisting of the lobe on its pedicle. However, in many cases, a deficiency of bronchial cartilage is thought to be the cause, leading to inappropriate collapse of the airway and the trapping of air. There can also be obstruction of the developing airway, which is the most frequently identified cause. No tissue damage is observed histologically, such as that found in acquired emphysema. The majority of cases show normal radial alveolar counts, but with no apparent maturation with age when compared to age-matched controls, suggesting a postpartum arrest of a sinus development within affected lung tissue. A minority of cases, however, show true alveolar hyperplasia with increased radial alveolar counts, which is sometimes referred to as a polyalveolar lobe. A polyalveolar lobe theory for the etiology of congenital lobar emphysema proposed that there could be a 3 to 5-fold increase in the number of alveoli in the affected lobes compared to normal. The reason behind air trapping in polyalveolar lobes is not known, and the airways and arteries are normal for age, number, size, and structure. Follow-up over 10 to 20 years of patients operated upon for congenital lobar emphysema with polyalveolar lobe etiology shows that these patients do well clinically. All patients have some pulmonary function abnormalities, specifically a decrease in airway conductance and forced expiratory volume. All patients had normal lung volumes and vital capacities despite losing 8 to 20% of their pulmonary parenchyma. So CLE is characterized by overdistension of one or more lobes of the lung. This leads to compression of the remaining lung tissue and herniation of the affected lobe across the anterior mediastinum into the opposite chest, causing displacement of the mediastinum. For the signs and symptoms, infants typically have tachypnea and increased work of breathing and often have cyanosis. Recurrent pneumonia or poor feeding with failure to thrive are less frequent presentations that may occur in milder forms. Unusual presentations of CLE are also reported in literature. So there has been a reported case who presented as unexplained neonatal tachypnea and another case of a 33-year-old lady with progressive exertional dyspnea. Clinical features of infantile lobar emphysema are those of a hyperresonance of the affected hemithorax associated with diminished breath sounds and deviation of mediastinal structures to the contralateral side. Physical examination reveals respiratory distress that often is accompanied by wheezing caused by airway compression. Cardiovascular anomalies are present in 14% of cases. Renal, gastrointestinal, musculoskeletal, and cutaneous disorders may occur. So in a Journal of Thoracic and Cardiovascular Surgery about lobar emphysema and congenital heart disease, they reported a total of 14 infants with congenital lobar emphysema, and 8 of them had congenital heart disease. The right middle lobe was the most frequent involvement. The cartilage structure of the bronchial system occurs between 4 and 6 weeks of the intrauterine period, and major changes occur in the development of the heart during this period. Therefore, the effect of this stage may affect both lung development and cardiac development. CLE is accompanied by cardiac anomalies 14 to 20% of the time. For this reason, CLE patients should be investigated for possible cardiac diseases before surgery. CLE may also be associated with other congenital cardiac malformations such as the following. Ultrasound and fetal MRI help prenatal diagnosis of CLE and associated complications. Ultrasound may demonstrate a gradual increase in echogenicity of the lungs. However, it can be too subtle, making the diagnosis difficult. Fetal MRI can differentiate CPUM and CLE because of its homogeneity and intact lung structure with stretched hilar vessels. Usually, the chest radiograph will demonstrate a hyperlucent lobe with features of compression and collapse of adjacent lung and depression of the ipsilateral diaphragm. The mediastinum is deviated and the contralateral lung may be collapsed. Ventilation perfusion scanning may demonstrate late uptake and clearance of isotope and reduced blood flow in the affected lobe. This investigation is particularly useful if it is unclear whether the problem is a pathologically distended lobe on one side or a congenitally small contralateral lung with secondary physiologic overexpansion. Bronchoscopy may reveal causes of intrinsic obstruction and permit the removal of a foreign body or inspissated secretions. An echocardiogram is valuable in evaluating the heart and great vessels. Lung CT is the gold standard in the diagnosis of CLE. It is useful in evaluating the anatomy of the emphysematous lobe and whether it has herniated into contralateral hemithorax. It is useful in demonstrating the nature of adjacent lobes of the lung. This investigation is also useful in excluding contralateral pulmonary hypoplasia. So what are the cyst-like lesions that can be seen in a chest CT scan? Let us first define what is a cyst. A cyst is a round, air-filled lesion with a well-defined thin wall, usually less than 2 cm, that is surrounded by a normal lung parenchyma. Pathologically, a cyst is any round circumscribed space that is surrounded by an epithelial or fibrous wall. An example is the congenital pulmonary airway malformations, which are hamartomous lesions that are comprised of cystic and adenomatous elements arising from tracheal, bronchial, or alveolar tissue. It can be solitary, well-defined, thin-walled, but it can also be multiple cysts of varying sizes and variable densities. Another is a bronchogenic cyst, which is an anomaly that results from abnormal budding or a branching defect. They are usually filled with fluid, and air-filled bronchogenic cysts are rare. They appear as well-defined, homogeneous, spherical lesion with a smooth or lobulated margin on CT scan. A cavity is a gas-filled space that is observed as a lucency or low attenuated area within pulmonary consolidation, a mass, or a nodule. A cavity is differentiated from a cyst by the presence of a thicker wall and a more irregular shape. A bulla is an airspace measuring more than 1 cm that is sharply demarcated by a thin wall. It appears as a rounded focal lucency or decreased attenuation more than 1 cm in size, and is bounded by a thin, usually almost undetectable wall that is not greater than 1 mm. Bullae are usually located in the subpleural lung rather than within the lung parenchyma. Bullae can be distinguished from cysts by their almost imperceptible thin wall, subpleural location, and accompanying adjacent emphysema. A pneumatocyst is a transient thin-walled gas-filled lesion, usually caused by pneumonia, trauma, or aspiration of hydrocarbon fluid. The mechanism underlying their formation is believed to be a combination of parenchymal necrosis and check valve airway obstruction. Pneumatocysts can be accompanied by adjacent consolidation or ground glass opacity as a result of recent pneumonia. Pneumatocysts appear transiently following recent pneumonia or trauma, which is an important distinguishing feature from cysts. Emphysema would show hyperinflation of a segment or lobe with tiny areas of low attenuation, usually without visible walls. With enlargement of the dilated airspace, the surrounding lung parenchyma is compressed, which enables observation of a clear border between the emphysematous area and the normal lung, which tends to be preserved even in a case of far advanced emphysema. Vessels within the affected lobe are attenuated and spread more apart. Honeycombing represents destroyed and fibrotic lung tissue containing numerous cystic air spaces with thick fibrous walls, indicative of the late stages of various lung diseases. Radiologically, it appears as clustered cystic lesions with 1 to 3 mm thick, well-defined walls in the subpleural region. Cysts are larger in size, lack a subpleural distribution, do not show associated fibrosis, and are isolated lesions in comparison with honeycombing. Bronchiectasis is an irreversible, localized, or diffuse bronchial dilatation. Bronchiectasis may be classified as cylindric, varicose, or cystic, depending on the appearance of the affected bronchi. Cystic bronchiectasis can also be mistaken for cyst when a dilated airway is viewed in cross-section. Bronchiectasis is usually distinguished from true cyst by careful examination of contiguous CT images. Findings such as tubular rather than spherical dimensions, branching patterns, associated bronchial wall thickening, centrilobular densities, and air trapping are also helpful for the diagnosis of bronchiectasis. For those patients with CLE having no respiratory symptoms, they can be managed conservatively since affected lobes does not compromise growth and development of adjacent lungs. Lobectomy is indicated in the event of respiratory distress. The traditional treatment of CLE worldwide is lobectomy, and thoracotomy is still the most common surgical technique for resection of CLE in childhood. Case series shows good outcomes for symptomatic patients managed with surgery. In long-term follow-up, patients treated with surgery may have generalized overinflation and chest radiography and pulmonary function abnormalities that are proportional to the volume of lung that was excised. Wheezing is the most common clinical symptom. Bilateral CLE is rarer, and in this case, two-stage sequential lobectomies is recommended, wherein the more inflated lobe is removed first. Intrapartum thoracoamniotic shunting is an option for large lesions and lesions that threaten fetal viability. Conservative treatment with close follow-up is recommended in infants greater than 2 months with mild to moderate symptoms and normal bronchoscopic findings. May-Zahab et al. Showed that 1 of 8 symptomatic patients needed a lobectomy in follow-up. In contrast to these findings, Takral et al. Presented case series for 21 patients. Unfortunately, 4 of 7 patients needed a lobectomy at follow-up. These findings suggest that asymptomatic CLE patients should be followed closely. Induction of anesthesia is very important in treatment of children with CLE. Excessive crying may cause a valve effect in the lung, which may increase hyperinflation in the affected lobe and increase mediastinal shift. This situation may lead to increased pressure on the vascular structures in the mediastinum. Because of this entity, the circulation deteriorates and cardiac arrest may occur. For this reason, inhalation induction is the preferred procedure in anesthesia of CLE patients. It is recommended that high-pressure ventilation should not be performed until thoracotomy and lung tissue is released, and the air pressure should not exceed 20 to 25 cm water. If necessary, patients should be ventilated gently. Prabhu and Joseph used mild intermittent positive pressure ventilation following muscle sparing. If possible, the pressure-controlled, volume-controlled mechanical ventilator mode may be useful. There has also been a report with the successful use of high-frequency ventilation in CLE patients. So, is the hyperinflation reversible? In a report of 30 children with CLE diagnosed over a 27 period, 9 were followed conservatively. The duration of follow-up ranged from 1 month to 17 years, and all patients demonstrated decreased hyperexpansion of the affected lobe. In a report of 20 children with CLE who were treated at a single institution, 11 patients were symptomatic at presentation. 6 with mild symptoms were managed conservatively and showed spontaneous improvement during follow-up, ranging from 6 months to 8 years. A report of 14 children included 4 children who had mild symptoms and presented at an older age, who were followed up conservatively. These children became asymptomatic during the follow-up period of 3 months to 4 years, although radiographic abnormalities persisted. The vast majority of children with congenital lesions do extremely well and have normal lung function after their lesions are removed. This is due to the rapid compensatory lung growth that occurs during childhood. Having surgery early maximizes this compensatory growth. So in summary, congenital lobar emphysema is characterized by hyperinflation of the pulmonary lobes, which can be either due to an intrinsic or extrinsic obstruction. Hyperinflation leads to compression of remaining lung tissues and herniation of mediastinum to the opposite chest. Almost all symptoms occur within the first 6 months of life. The diagnosis can often be made from its characteristic appearance on a chest radiograph, but the gold standard is a chest CT scan. Studies in case series suggest that the hyperinflation of the lung lobe can be reversible. Management includes conservative treatment for asymptomatic patients and lobectomy for those having severe symptoms. CLE can be life-threatening when symptoms are severe and surgery is not done, but overall, majority has a good outcome even in patients who underwent lobectomy.